Hello, and I'm Katie Kompoliti from Chicago, and I'm here to moderate the question and answer session with Dr. George from Michigan and Dr. Tony Lang from Toronto. And I'm going to start with some of the questions about diagnosis. And even though, Dr. Lang, you touched on that, people still seem to struggle with the question, why is MSA so hard to diagnose?
Well, I think full-blown MSA, once all of the features are present, is not that difficult to diagnose. Recognizing that many of these features overlap with Parkinson's, but they tend to occur far earlier in MSA than in Parkinson's disease. So it's difficult to diagnose at the earliest stages because there is a great deal of overlap in the clinical features. These patients can look very much like they have Parkinson's disease, or they can look like they have a cerebellar ataxia of many other types. And so it's the need to recognize the more subtle features that might not be present to a great extent, like the blood pressure changes, the bladder abnormalities, etc., that then make the physician begin to consider the diagnosis. In the case of the Parkinson's side of things, the response to levodopa has been emphasized, and certainly if you fail to respond to levodopa, that's a very helpful clue to an earlier diagnosis, but that doesn't take into account the fact that many people with MSA get quite a good response to levodopa early on, and they may maintain a response for far longer than most neurologists really appreciate, although that response tends to fade and fail and sometimes is lost completely. But I have a lot of patients with MSA with Parkinsonian features who continue to respond to levodopa to a certain extent for a very long part of their course. So it's a hard diagnosis because of the overlapping features with other conditions.
And so another question here is for those patients who present mostly like Parkinson's disease. And what are the red flags you feel that have led you to reclassify them as MSA in the first few years of the disease, besides the response to levodopa?
Shall I continue, or does Dr. George? Maybe Dr. George wants to take that.
Yeah, I was going to say, if you remember the Venn diagram from the talk that was just broadcast, as people move from one of the major areas of having Parkinson's, cerebellar, or pure autonomic failure towards the center where they combine the three. So you often see autonomic problems, which happen in regular Parkinson's disease, coming on more severely and more early in the patients with the Parkinson's presentation. Also, more problems with falls more early in the course can be a red flag, though you have to remember that that can be a red flag for other diseases like progressive supranuclear palsy.
Okay. And there was another question from a young patient, and how many tests do you need to do to be certain that the diagnosis is MSA? How many other conditions do you exclude for young people who get diagnosed with MSA and have mostly cerebellar symptoms?
Well, there's a pretty wide variety of cerebellar diseases that can early on look like they might be multiple system atrophy. So unfortunately, there's often not specific tests that can answer that question. The real test is tincture of time and seeing how people progress and develop more clinical symptoms. At the end of the talk, I mentioned some of the assays that are being developed to look at protein misfolding and aggregation that may lead us to some tests that we can do early in disease. But those results are just being published in the last couple of years, the basic science that underlines them. The fact that most of the people who published it seem to have taken out patents on it certainly suggests that they think it will be developed into a useful clinical test, and I personally believe it also, but that's some years down the line yet.
Okay, so next question, and let's throw that to Dr. Lang, is that there appears to be some cases of MSA that are pretty aggressive. They're very fast. Does that appear to represent one type of the 3 strains of MSA, and which type?
Well, I don't think there's any way, apart from looking at the course to the point that we first see the patient, to predict what the course is going to be going forward. Yes, some patients do have a very aggressive, more malignant course. It has been suggested that the Parkinson's subtype may be more aggressive than the cerebellar subtype, but there is some disagreement about that. I think that there are studies that show the younger the age of onset, the slower the progression. So the older patients do have a more rapidly progressive condition, but again, that's not always the case, and we see exceptions to all of these rules. So what makes a more aggressive form, we don't know. It may be that in the future we will find, you mentioned the word strain, we may find that studies of postmortems will show differences in the way the proteins behave in the more aggressive forms, or the spread of the protein in the brain is maybe different in the more aggressive forms, but we just don't know. I think that's going to take a lot more research.
Okay, thank you. So then this one is for Dr. George. What I've heard people saying that MSA begins in the gut. What does that mean? And if it does begin in the gut, that means that diet can prevent it or make the symptoms better. And what about this this thing I saw on the internet about fecal transplants?
Well, what was the last part on the internet?
Fecal transplants.
Oh.
Or implants. Yeah.
Yeah, so fecal implants can be used to try and change the gut flora, the bacteria that are flourishing in everybody's gut, which varies from person to person. And how much this may or may not modify the clinical situation in folks, particularly who use levodopa, where absorption in the gut appears to be very much affected by the gut flora, it still remains to be seen. The first part of the question, you can find the abnormally folded protein alpha-synuclein in the gut of patients with Parkinsonian disorders. You can also detect it in skin. You lose sense of smell early in true Parkinson's, and people say that maybe it starts there. And the fact is, we don't know exactly where it starts. And as a target, the gut, we would have to know that it's going to happen before you have any symptoms if it was starting in the gut. So it's not clear exactly how we can take advantage of that. It may be in the future we'll know something about modifying the gut flora to reduce the risk of developing these. At this point, that's not really established. There was something else I was going to say there, but it slipped my mind.
Okay. So the next question is about gene therapy for MSA. And is there a study looking into gene therapy for the treatment of MSA? Dr. Lang?
So there are various forms of gene therapies that are being considered in neurodegenerative diseases. When we talk about gene therapy, we usually mean that you use a gene to put in another kind of protein into the brain that might be missing or may be present in suboptimal amounts. So this is not, for example, like genetic diseases where you are replacing the defective gene. So that's very, very different. So in this case, the gene therapy that is being considered in multiple system atrophy, as I understand it, is using a gene to put a growth factor, glial-derived neurotrophic factor, or GDNF, into the brain, not because GDNF is deficient, but to try to increase the amounts of GDNF that then may cause growth of cells that are damaged in the disease. And the cells that may be encouraged to grow or become replenished are both dopamine cells that are deficient in MSA, as well as cells that the dopamine cells talk to in the striatum. So there are sort of two sides to the equation in MSA, a loss of dopamine cells on one side and a loss of the cells that the dopamine cells talk to on the other side. In Parkinson's, you lose the dopamine cells, but you retain the cells that receive the dopamine information. Whereas in multiple system atrophy, you've got these two cells on the equation that are both damaged. And GDNF does have the potential for encouraging growth of both sides of the equation, cells on the dopamine side, cells that the dopamine cells talk to. This is a very experimental approach. It's something that I was mentioning to the group earlier before we came on that I had encouraged a company to consider a long time ago, just infusing the growth factor, not using a gene therapy approach. Interesting idea, something that we're going to look at very carefully and watch with enthusiasm and interest, but it remains a very experimental trial that we'll have to wait to see how it comes out.
Okay, thank you, Dr. Lang. So this one is for Dr. George. A lot of patients with MSA and autonomic failure, especially neurogenic orthostatic hypotension, had put a lot of hope on the Theravance trial, ampreloxetine. And there was a public announcement about the failure of ampreloxetine to meet their primary endpoint. Can you elaborate on that? And what it means for the treatment of NOH?
I don't know the details of how the study failed, but I would just, Dr. Lang was just emphasizing how experimental the gene therapy is. All research is exactly that. It's research because we don't know the answer. So it's not unusual for things that we have good reasons to think might work, turn out that they don't work. And we just have to move on to the next available promising looking mechanism or medication for trial.
And this one is for Dr. Lang, and this attendee is asking, feels that the symptoms of MSA came up after they had surgery under general anesthesia. Is there any evidence that general anesthesia can trigger MSA?
To my knowledge, there's no evidence whatsoever. There are epidemiological studies that have not linked any surgical procedure to this type of neurodegenerative disease, nor any other that I'm aware of. It's not uncommon for people who have an underlying brain disease to first be aware of their symptoms after some experience, a traumatic experience, undergoing surgery, whatever. And it's important to emphasize that these diseases are usually in the brain long before the patient actually presents with the clinical symptoms. How long in the case of MSA, we don't know. Certainly in the case of Parkinson's disease, probably decades before the patient actually presents with the movement disturbances. And so it's very likely that the same is the case for MSA, maybe a shorter period of time given the speed of progression that we normally experience in MSA, but it's still likely to have been present for at least a couple of years and probably considerably longer in the brain before someone first develops symptoms. So if you wake from an anesthetic and within a couple of days or weeks, you first have the symptoms of MSA, it's highly likely that the disease was there long before you underwent the procedure.
Can I just add to that? In these neurodegenerative diseases, particularly the Parkinsonian forms, there are clearly important compensatory mechanisms that go in the brain to adapt, which is part of the reason we have this long prodromal phase where you're not so symptomatic that Dr. Lang was just referring to. And it does seem in patients who are known to have a diagnosis of Parkinson's for certain and many of these other neurodegenerative diseases, that general anesthesia results in a temporary decompensation, and people get worse who have these diseases for days to a week or so after they have the anesthesia. So it's quite possible that you can never have had symptoms and decompensate from the anesthesia. The symptoms become evident for a while, so that will be the first time you see them, but it's not at all causative. It's just pulling back the curtain to see what's brewing in your brain.
A very important animal study that was done by Michael Zygmunt from Pittsburgh a long time ago, where he made rats dopamine deficient, quite dopamine deficient, down to 90% loss of dopamine or more. They recovered from the treatment that caused that, but they were still dopamine deficient, and you couldn't tell the rats were abnormal. They behaved entirely normally because of the compensatory mechanisms that Dr. George just referred to. Then he put those animals in a stressful environment, into a water bath where they had to swim around and not sure whether they were going to be able to get out of the water bath. And at that point, they all become symptomatic with the stress of being in that circumstance. So these were animals that were very abnormal with respect to the dopamine system, that you couldn't tell clinically that they were abnormal until the stress event occurred.
Okay. So, Dr. George, this is probably a follow-up on the question I asked before. How can diet affect MSA? Are there any recommendations, low protein, high protein diet, for example?
Well, it's not a direct effect on the disease, but if you have Parkinsonian disease, MSA or other sorts, and are taking Sinemet, carbidopa, levodopa, protein digestion releases amino acids into the bloodstream where it interferes with the ability of levodopa to get into the brain and help the Parkinsonian symptoms. So this is a relatively small effect, but in people where the amount of levodopa getting in is really critical, trying to you need your protein, but trying to modulate your protein intake so that it's relatively constant and not lined up directly with taking your levodopa can be helpful. Another big issue is constipation. And again, modifying your diet in terms of fiber, getting plenty of fluids. And we just heard this week that there's probably evidence that probiotics can help with some of the constipation in these diseases. So there's things you can do with diet to help modify specific symptoms that go on with the disease.
So the next question is somebody has MSAC and they start to have a lot of tremors that don't respond to Sinemet. Are there any other medications that can work for the tremors?
Well, we frequently will try amantadine. Parkinsonian tremors often respond to Sinemet, but often don't. And amantadine a little more consistently helps with Parkinsonian tremors. The best drugs for suppressing Parkinsonian tremors are the acetylcholine drugs, but those drugs also make problems like orthostatic hypotension and memory problems worse. So we're kind of cautious about using them in patients with Parkinsonian symptoms.
So there is a question, thank you so much, Dr. George. There's a question about long-term use of lithium in MSA symptoms. Is there any research on that?
I'm not aware of any. Lithium theoretically could have effects on certain cellular pathways that may be important in neurodegenerative processes. This was particularly of interest in progressive supranuclear palsy. However, tolerability was very, very poor. And a study of lithium was initiated and then scrapped very quickly because the vast majority of patients who came into the study early on had to stop because of side effects. Lithium has a lot of side effects, and I'm not aware of it being associated with MSA causatively, but I'm not aware of it being helpful in MSA either, and we certainly wouldn't recommend its use.
Okay, the next question is about B12 and what role does B12 deficiency can play in the symptoms of MSA. And this person who's asking this question would like to take a minute to send a warm thank you to the doctors for their contribution to these sessions. So, Dr. George, you want to take the B12 question?
Sure. Vitamin B12 is immensely important for nerve cells. So on the one hand, it doesn't play any direct role that we know of in MSA. On the other hand, it's certainly a very helpful thing to make sure that your vitamin B12 levels are good for all sorts of nervous system disease. In addition, low vitamin B12 can cause neuropathy, which in my talk I mentioned can be a really confounding effect. And one of the speakers at the Movement Disorders Conference this week made some allusions to the upcoming new diagnostic criteria and mentioned that neuropathy might be an exclusionary criteria. That is, you'd be unable to establish a diagnosis of multiple system atrophy in someone with neuropathy. So it would not only be a additional symptomatic problem to the MSA to have inadequate B12, but might lead to further confusion in establishing a diagnosis.
Thank you very much. So next question, can cannabis in the form of THC or CBD oil help the symptoms of MSA in any way? Dr. Lang?
There's generally an interest in that in every field. No matter what your symptoms are, people are interested in whether cannabis is going to be able to help. Certainly, CBD oil has been shown to be effective in helping nausea, helping pain syndromes, maybe helping sleep and anxiety, but there is no evidence that these treatments are effective in actually affecting or changing the underlying disease process. And in fact, particularly with THC and its effects on cognition, thinking, etc., would probably be detrimental. Certainly in Parkinson's disease, we've seen people have hallucinations and a variety of other problems with these treatments, and we discourage them using these treatments, except for those reasons that I outlined before. And I think good studies need to be done on their use for these purposes. But I generally would not recommend using them, and they may actually increase the disability. If you're unsteady, for example, with your cerebellar dysfunction or with your Parkinsonism, and then you take THC, you're going to be more unsteady.
Okay,
Yeah.
the next question is about
Yeah, I'm sorry. Could I just throw in about
Yes,
cannabis
yes,
and
please.
CBD? Yeah, to really answer the questions would require well-designed research, because anecdotal evidence doesn't help, because these drugs can make people feel better, regardless of what their problem is. So that you really need carefully designed research, which unfortunately in the US, where one of the biggest funders for research is the federal government, and federally in the US, it's still considered an illegal drug. So it's very hard to get funding for research in the US on these agents.
So they have to come to Canada where it's legal.
Yeah.
So the next question is about intranasal insulin. This person heard something about intranasal insulin that could be helpful for MSA in the recent past. Is there any research you're aware of or anything been done regarding intranasal insulin?
I think it had been discussed as potentially disease modifying at one time. I don't think that that has been pursued any further. There may have been some preliminary studies that were negative. I'd have to go back and look at the data, but I don't think there's any anyone pursuing that actively currently. I may be wrong.
So the next one is about coenzyme Q10 and its role as a supplement in patients with MSA. Dr. George?
So coenzyme Q10 is another vitamin that is particularly important for mitochondria. Mitochondria are the energy producing units that are in all cells and are certainly important in the cells of the nervous system. And there have been studies showing with regular Parkinson's disease that people function better with extra CoQ10, even though the underlying Parkinson's disease doesn't seem to be affected. So again, this is something that is probably a good idea to make sure you have adequate amounts in your system so that you can function as well as possible, but there's no direct evidence from the trials that I know of that it actually is in any way disease modifying.
So there is an attendee who has more questions about neuropathy as an exclusion for in the diagnosis of MSA. Can we come back to that point?
So neuropathy, when we use that term, we typically mean that the peripheral nerves, the nerves that go from your spinal cord down to your legs or your arms, are damaged. So this is disease outside the central nervous system. That's not the brain and the spinal cord. It's the connections from the spinal cord to your limbs. And generally, neuropathies follow what is often referred to as a dying back process. So the longer the nerves, the more the damage. And so you feel the problem in the places where the nerves are longest. And where they are the longest, typically in your legs first, down in your toes. And then you have problems progressing back up in what is often in the neurology terminology a stocking and glove abnormality. And so peripheral neuropathy means damage to your peripheral nerves outside the central nervous system. Multiple system atrophy is a disease of the central nervous system, almost exclusively. And so if you have a very clear peripheral neuropathy, either you don't have MSA, or you have MSA with another cause for your neuropathy, like diabetes or something like that, which is very common. But the problem is that if you have an obvious peripheral neuropathy, it becomes, as I think Dr. George mentioned earlier, it becomes very difficult to be sure that you've got MSA. And so he was talking about B12 deficiency earlier, and that contribution to a peripheral neuropathy. So if your neuropathy is due to your neurological disease, then your neurological disease is not MSA.
Okay, thank you, Dr. Lang. So the next question is about stem cells. Is there any research that about with stem cells in MSA? Who wants to take that question?
I guess I can start. The hope of stem cells in being able to replace all damaged neurological regions is really, unfortunately, quite naive. A lot of people think that you just would put the stem cells in and these stem cells would be smart enough to know where to go and to what cells to replace. Unfortunately, one of the reasons for the term multiple system means that many different regions of the brain are affected. Many different types of cells are affected. And so remember, I was talking about a dopamine cell and a cell that it talks to. Both of those sides of that equation are damaged. So to think that a stem cell is going to be able to replace both sides of the equation and rewire everything really is not realistic at all. And so I think at this point, stem cells probably are not something that we would realistically think is useful for multiple system atrophy. Maybe they'll be useful in terms of understanding multiple system atrophy and doing the basic research that then would bring important breakthroughs to the treatment. That's certainly a possibility, but not in terms of therapeutics, at least in the foreseeable future.
Yeah,
So
I would just add that there is active research, not in MSA specifically, often more pointed towards Parkinson's disease on what you can do with stem cells, but it's still very basic science about can you get them in, can you get them to form connections of any sort, how do you keep them from deciding to grow into tumors, how do you get them regulated and so forth. So there's definitely research in that area, but it's way basic and nowhere close to anything clinical.
Well, in fact, stem cells can be induced to make dopamine cells. Mm-hmm. And in Parkinson's, that's the whole interest. The large interest is to take your stem cell and then force it down a pathway that then makes pure dopamine cells. Now you have this wonderful source of an infinite number of dopamine cells that then you can put into the brain and replace the diseased and damaged dopamine cells of the host. When you have a disease that is mainly dopamine cells, for example, early Parkinson's, that actually might be useful. But also it's important to remember that as Parkinson's progresses, it becomes far more than just dopamine as well. And so maybe in Parkinson's, in the earliest stages, or certain forms of Parkinson's where we know it's mainly dopamine, there are certain recessively inherited forms of Parkinson's that it might be very useful. That's another thing, but not in the case. And in fact, we are seeing proposals coming forward, studies of stem cells that have been forced to go down this dopamine pathway that are actually starting now in Parkinson's disease.
I want to point out one other issue. One of the first things that got people really thinking about the fact that misfolded proteins can spread from cell to cell and cause cell damage in different cells and different areas of the brain in Parkinson's, as well as other diseases like MSA, was that there were early trials putting in these dopaminergic cells. And at autopsy, they found that the grafts had caught the Parkinson's disease from the cells around them, and also were developing the misfolded protein and undergoing the same fate.
Very good. And is there anything promising on the horizon? Anything in the pipeline? Any medications that look promising coming up for MSA?
Well, there are a variety of different approaches being taken to deal with misfolded proteins and interfere with the aggregation and so forth. And some of them probably hold promise. And I think what's most promising to me, as I alluded to at the end of the talk, is the idea of having these aggregation assays to see exactly what form of misfolded protein you have. And then we could probably choose specific agents that target that kind of misfolding, that kind of aggregation. And I think that's going to really help us take off with these agents.
Well, the next question is, how can somebody tell whether they have MSA or Lewy body disease?
So Lewy body disease, that term incorporates a few different conditions, commonest being Parkinson's disease. Most people, when they use the term Lewy body, most people outside the neurologists and movement disorder specialists are thinking about something called dementia with Lewy bodies. Dementia with Lewy bodies, most people have fairly soon after the onset of their symptoms, fairly significant cognitive disturbances. This is a condition that occurs more later in life. Multiple system atrophy tends to begin earlier in life than dementia with Lewy bodies. Sometimes dementia with Lewy bodies in an elderly individual will start with autonomic disturbances. So when I see somebody at the age of 75 or 80 who begins to get orthostatic hypotension, I don't immediately think multiple system atrophy. If they've got a little Parkinsonism, for example, but they have a prominent early autonomic problems with orthostatic hypotension, at that age, dementia with Lewy bodies is far more common than multiple system atrophy. So age of onset is helpful in differentiating the degree and timing of the cognitive difficulties. Multiple system atrophy, when they develop cognitive troubles, these are usually far milder and often not really very overt. A small proportion will get significant cognitive problems, but when we see that, we're always concerned about whether our diagnosis is correct. So severe early cognitive disturbances would really be far more common in dementia with Lewy bodies as well. So it's age, timing, and the clinical features. And then other autonomic problems, prominent bladder difficulties with urinary retention, for example, that would be far more common in multiple system atrophy. And then the imaging features can be very, very useful as well. An MRI scan in someone with Parkinsonism or cerebellar dysfunction would be very helpful too. And then finally, the cerebellar features would not be seen in dementia with Lewy bodies either. So it really is the Parkinsonian phenotype where the diagnosis is more a bit of a challenge sometimes.
Thank you, Dr. Lang. There is, has diabetes ever been an indicator for MSA?
Not that I'm aware of. As actually mentioned in my talk, it often leads to things that can complicate the diagnosis of MSA, but it's not thought to be something that predisposes one to developing MSA. There's interest these days at the research level in insulin type receptors in the brain and how they may help to treat particularly Parkinson's disease, but probably MSA as well. But there's no connection to the cause of the disease.
Yeah, there is some evidence that diabetes may be a bit more common in Parkinson's, and there is some evidence that the treatments for diabetes may influence Parkinson's, as Dr. George has indicated. But to my knowledge, no relationship between diabetes and MSA. Sorry, as you mentioned, I think it should be emphasized further. It can make the diagnosis of MSA very difficult early on. If you've got somebody with diabetes, that's one of the commonest causes of autonomic disturbances that we see. So an individual comes in, they've got urinary problems, erectile dysfunction, orthostatic hypotension, but they've got diabetes. And now they present with Parkinsonism or cerebellar features, and their autonomic problems have occurred early. So we're forced to be thinking about MSA in the differential diagnosis. But if they've got diabetes, it becomes very, very difficult to know.
Okay, there is somebody here who's asking the question about ISRIB, ISRIB, which has been studied with Alzheimer's disease and prion disease. Has there been any application of ISRIB to MSA?
Not that I'm aware of.
What does it mean? I'm sorry.
I don't know. I just looked it up. It's some stress response inhibitor that reverses the effects of ELF2A phosphorylation something.
Yeah, I think it's supposed to help prevent protein misfolding.
Yeah. So nothing in MSA.
I mean, it might have potential there, but as far as I know, nobody's looking at it in MSA.
Very good. So there is again a question between, it's the same person who is asking probably about lithium-induced cerebellar ataxia and MSA, who had a question before. How can you tell the difference between lithium-induced cerebellar ataxia and MSA?
Well, lithium can cause toxicity to the cerebellum. It is not associated with all of the other features that we use to support the diagnosis of multiple system atrophy. So you don't see the autonomic failure, you don't see the Parkinsonism, you don't see the same imaging, MRI changes. The cerebellar region in someone who's had lithium toxicity, you see shrinkage of the cerebellum. But to my knowledge, you don't see the other characteristic features. And somebody was asking, I saw about the hot cross bun sign. That is
yes.
A cross. There's a part of the brain stem called the pons, and the cerebellum attaches to the back of the pons. And in cerebellar atrophy, or the MSA-C component, you see sort of a cross, very similar to the buns that are produced during Lent, that have been part of long tradition in Christianity, I guess. And so that feature of the MRI scan, that cross of the bun of the pons, is not a feature of the cerebellar atrophy of lithium toxicity. And there are other features that we don't need to go through, but you just don't see them. So it's a very different animal.
So we have a few minutes. There is another question, not in the chat box, but from the general, the blogs on the patient sites on Facebook. What about those patients with severe gastrointestinal symptoms like nausea, stomach pain, who are found to have gastroparesis? How do we diagnose and treat those?
Well, if you have gastroparesis, there are various radiologic studies that we can do to try and confirm that that's what the problem is. There are limited numbers of medications that can enhance gut motility, but there's certainly one of the things we try when there's gastroparesis and that kind of slowing of the gut. And then you can help to modulate symptoms with drugs that keep, interfere with constipation and with diet manipulation.
Okay.
Generally, though, I've been impressed by a lack of profound symptoms from gastroparesis in multiple system atrophy. there are some autonomic disturbances. For example, sometimes in diabetes, you see very severe problems with gastroparesis. On the other hand, in MSA, you asked about nausea and vomiting. That's generally not a feature of multiple system atrophy. Now, when we start treatment with levodopa, nausea and vomiting can be a side effect. That's not uncommon at all, but severe gastroparesis and problems as a consequence of that, in my experience, are not typical of multiple system atrophy.
Okay, very good. We've reached the end of our allocated time, and I would like to echo the feelings of those grateful patients before and thank the doctors for taking the time and doing this, the patients and being on the forefront of fighting for this disease. Okay, thank you very much, all of you.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.